Hello, and thank you for inviting me to this presentation. I'm going to talk today about the vaccine implementation in the United States. First, I just want to say that I have no potential conflicts of interest to disclose. So 3 vaccines have received emergency use authorizations from the FDA in the United States. I think many here are aware of those 3 vaccines, but I do just want to outline the differences in those vaccines. The Pfizer-BioNTech vaccine is authorized for persons aged 12 years and older, while the Moderna and J&J or Janssen vaccines are authorized for persons aged 18 years and older. All 3 vaccines were tested in diverse adult populations, including minority groups and older adults. All of the available vaccines have proven effective at preventing serious illness, hospitalization, and death from COVID-19. And all COVID-19 vaccines currently available in the US are effective at preventing COVID-19 as seen in clinical trial settings. So the research provides growing evidence that mRNA COVID-19 vaccines offer similar protection in real-world conditions. However, it is currently unknown how long the protection from receiving a COVID-19 vaccine might last. Here, I'm going to look at the vaccine implementation and the multiple components. Really, we started with planning. Public health impact of COVID-19 vaccines relies on rapid, efficient, and high uptake of a safe and effective vaccine. So while this image looks sequential for planning purposes, as many of you know, we do it in parallel. We began COVID-19 vaccine implementation with a large planning process in the summer and fall of last year. Building off of years of pandemic preparedness work, we created a playbook, which we shared with all the 64 jurisdictions in the United States to help them create their customized plans and strategies for administering COVID-19 vaccine. This was an iterative process as we received more information about how and when vaccines would be ready for use. We communicated and continue to communicate with jurisdictions via calls and emails on a regular basis. Our goal is to implement a vaccine program to get vaccines into arms. So there were multiple components for the vaccine implementation program. The impact, as I said earlier, really involved rapid, efficient, and high uptake of a complete vaccine series with a particular focus on those at increased risk of severe COVID-19. This simplified diagram shows the multiple pieces that came together for our COVID-19 program. So in a limited supply setting, we need to prioritize populations, which I'll discuss further in a little bit further on in the presentation. Once we decided how to prioritize, the vaccines need to be allocated. When we started, vaccines were allocated pro rata based on population size. Following that was the conversation around distribution. We needed to ship vaccines from manufacturers to the sites for administration. And then the administration component was shots into arms. Are they incredibly important, but sometimes very complicated to do? So some of these vaccines have not been optimized for use in the way that they may have if we had spent longer with the development process. There were large cold chain requirements as well. So most of these were surmountable obstacles, as we demonstrated, but they were obstacles. And we continue to work very closely with states, localities, territories, and jurisdictions with regards to these issues. Throughout the entire process, safety was of utmost importance. We are monitoring safety and effectiveness. We're watching updates for coverage and making sure that people get their second dose as well. As we look at the effectiveness as well, that helps us as we plan forward for the future. Overlying everything was our communication and stakeholder engagement. We need to engage lots of people early and often for a successful vaccination program. And our communication needs to be ongoing to partners and to the general public, I think, as we've demonstrated. The data systems and monitoring systems also were extraordinarily important with regards to our program. We had real-time data coming in that allowed us to monitor supply and vaccine uptake. And then also underlying all of this were the regulatory considerations that provide checks and balances for our program. So there were several important stakeholders who played a crucial role in planning for the successful COVID-19 program in the United States. The jurisdictions themselves, so this was the US states, territories, and certain cities. These groups are the closest to the population and absolutely critical in informing our overall strategy, getting feedback on programs and identifying challenges in real time about the rollout of the program. Also, with regards to federal entities, we work very closely with the Department of State, the Department of Defense, and Veterans Health Affairs. Private partners as well. These were groups such as hospitals, pharmacies, and distributors that provide infrastructural leverage in ensuring that the vaccines can be reliably manufactured, distributed, and administered. And then underscoring a lot of this was health equity. It's been prioritized at all levels. Ensuring that equity is maintained across the response has been a clear focus for vaccine administration. Clear metrics exist to drive transparency, accountability, and monitoring of vaccine access to groups that have been disproportionately affected by the pandemic. So this has been a complicated process. While it was built on existing systems, vaccinating the entire population in a really short period of time was something that really hadn't been done before. When COVID-19 vaccine first became available in late 2020, there was limited supply. So the distribution and administration strategy has been dynamic and adjusted as the volume of available vaccine doses increased. In the initial phase, on the left of this chart, we had limited supply, meaning the vaccine supply really wasn't great enough to meet the demand. So frontline workers and groups more vulnerable to COVID-19 were prioritized for vaccine administration. It really was a phased approach, and I'll be discussing this more in the next slide. You also see that the initial phases overlap. This is because jurisdictions vary greatly and implemented strategies to work through their priority populations in a way that made sense for their community. As a larger number of doses became available, we moved rapidly through every sector of our communities to implement vaccination using traditional and non-traditional partners. So part of our responsibility as a public health agency in this phase was making sure vaccine is available to populations who may not typically have had easy access, or in populations where we expect to see increased vaccine hesitancy. As we moved into a phase with steady, predictable vaccine supply, more populations became eligible for the vaccine. We're moving to a point where demand for vaccine becomes the bigger constraint. And we're continuing to rely on robust communications and other strategies in order to combat vaccine hesitancy and ensure that the national population reaches an agreed upon level of vaccination. So we wanted to touch a little bit on our phased approach. The Advisory Committee of Immunization Practices, or our ACIP, is the National Immunization Technical Advisory Group, or NITAG, in the United States. It's an independent federal advisory committee of medical and public health experts that provides advice and guidance to the CDC director on the most effective means to prevent vaccine-preventable diseases in the United States. So ACIP worked for several months to answer the question, which groups should be recommended to receive COVID-19 vaccine based on ethical principles, including maximize benefits and minimize harm, promote justice, mitigate health equities, and also promote transparency. So on Tuesday, December 1st, 2020, the ACIP voted on the first group to be vaccinated. Phase 1 included healthcare personnel and residents of long-term care facilities, or LTCFs, be offered vaccination in the initial phase of implementation. The goals ACIP used to determine these groups were decrease death or serious disease as much as possible, preserve functioning of society, reduce disease burden on existing health disparities, and increase chance for all to enjoy healthy and well-being. The next groups to be included phase 1B, which was the frontline essential health workers, including public transit and educational sector workers. This we also worked with the jurisdictions to help them identify who their essential workers were. Also, the age group 75 and older. Then phase 1C, this is 65 and older, and 16 to 65-year-olds with underlying medical conditions. And then other essential workers, including logistics, media, public health workers as well. So I do want to stress that while ACIP and CDC make national recommendations, we understood that there would be a level of local adaptation. The phased vaccine recommendations were meant to be fluid and not restrictive for jurisdictions. So we worked with a lot of jurisdiction input. It's not necessary to vaccinate all individuals in one phase before initiating the next phase. So those phases would overlap. For COVID-19 vaccine prioritization, the US adult population was broadly divided into overlapping categories based on essential workers, as well as age and presence of underlying medical conditions. And we also recognize that people don't necessarily fall into one category. So with regards to distribution, as vaccine supply increased, distribution and administration sites expanded and more options became available for the US population. During the initial phases of distribution, there was limited supply of COVID-19 vaccine. Also, the initial dose had complicated cold storage requirements. So in those early phases of distribution, vaccines were administered in targeted areas to focus on priority groups, including hospital personnel, long-term care facility residents, and public health clinics. So you can see this on the left, where the healthcare personnel and others were included. Later in the vaccine distribution, a larger number of doses became available, and administration sites began to expand with a focus on ensuring equity, as well as increasing access. Pharmacies, doctors' offices, long-term care providers, homebound populations, mobile units, public health clinics, hospitals, mass vax clinics, all of these began to expand and were included in the jurisdiction's strategies. With regards to our data and monitoring systems, we worked very closely with Health and Human Services, which is our Ministry of Health, the Department of Defense, and other partners to build robust data and monitoring systems to track manufacturing, delivery, and administration of vaccine doses. So systems such as Tiberius help provide visibility to the jurisdictions on the entire vaccine supply chain, not just until doses reach sites, but even on administration and health equity metrics as the general population got vaccinated and continues to be vaccinated. The CDC COVID data tracker is publicly available on the CDC website and is externally facing. Daily updates show the status of the US implementation effort down to the county level within a state. The data tracker also includes demographic information. So the system helped to ensure transparency and accountability. So across the program, other efforts such as vaccines.gov, which is a portal to locate vaccine inventory and also to book appointments, and vSafe, which is a mobile-based app around adverse event monitoring system, were also in place. In addition, there are several behind-the-scenes systems that enabled us to coordinate with our third-party logistics and also with the provider sites. I do want to touch a little bit on the strategic partnerships that we used. They really contributed to the increased access and equitable access of COVID-19 vaccine. They also played a really important role in distribution. So our strategic partnerships were critical to the success of our program in getting vaccines in arms. As an example, I'm going to focus on the Federal Retail Pharmacy Program, or FRPP. So the FRPP for COVID-19 vaccine was a public-private partnership that involved 21 national pharmacy partners and networks of independent pharmacies that represented over 40,000 retail and long-term care pharmacy locations nationwide. Additionally, we worked with federally qualified health centers. So to ensure our nation's underserved communities and those populations disproportionately affected by COVID-19 were equitably vaccinated against COVID-19, the HRSA, or Health Resources and Services Administration, which is an arm of HHS, and CDC launched a program to directly allocate a limited supply of COVID-19 vaccine to select HRSA-funded health centers starting the week of February 15. So coordination of this was at the federal level with the goal of increasing access to vaccine, improving vaccine uptake, and decreasing the logistical and operational burden on public health. So the vaccine supply was in addition to the jurisdictional supply, and the allocations provided for this program was separate than the jurisdictional weekly allocations. I wanted to talk a little bit about the COVID-19 vaccine milestones in the United States. On this graph, you can see the date on the x-axis and the vaccine doses administered on the y-axis. As you can see early in the program in December, the Advisory Committee on Immunization Practices voted for the use of Pfizer and then Moderna vaccine, and they quickly rolled out. Late December, the Pharmacy Partnership Program for Long-Term Care Facilities was launched, covering facility residents in over 63,000 facilities across the United States. In early February, the joint CDC HRSA program was launched that I spoke about a little bit earlier, initially with 700 sites, and as you can see, expanded to several other sites as the program progressed. In late February, the J&J vaccine was authorized by ACIP as well. In early March, there was a program call by the Health and Human Services Department around making teachers, school staff, and childhood workers eligible for the COVID-19 vaccine, leading to nearly 80% being vaccinated by the end of March. You can see also that by March 12th, we reached 100 million vaccine doses administered. We began a federal dialysis program as well in an effort to provide vaccinations to people receiving dialysis and healthcare personnel in late March. By mid-April, the US passed 200 million doses administered, and also by mid-April, over 90% of the US population was within 5 miles of vaccine sites, leading to increased access. And then in early May, ACIP recommended Pfizer vaccine in adolescents aged 12 to 15. I do want to touch as well on this vaccine safety monitoring. I won't spend a lot of time on it, but it is extraordinarily important, I think, as everyone here knows. So CDC, FDA, or the Food and Drug Administration, and DoD have put into place a robust systems to monitor vaccine safety in the US. These systems enable both active and passive surveillance and tracking of COVID-19 cases over time. So the vaccine safety monitoring plan uses existing established systems, as well as creating new systems to monitor COVID-19 vaccine safety. One of the new safety monitoring systems is vSafe. I mentioned it a little bit earlier. It's a smartphone-based tool that uses text messaging and web surveys to provide personalized health check-ins after you receive a COVID-19 vaccine. I think a key element of building trust in these vaccines is to communicate clearly on the vaccine safety process and systems, as well as providing safety data and monitoring results when available. Ongoing communication for healthcare providers and the general public has been critical for vaccine confidence. CDC provides guidance for healthcare providers around storage, handling, administration, communication, as well as information for the general public to educate them on the different vaccines, on potential side effects, safety, ongoing monitoring, adverse events, among many other things. So CDC has released numerous communication toolkits for different audiences as well. This has included our long-term care facilities and medical centers, toolkits for community organizations, as well as for workplace employers. A couple of examples include guidance summaries and training for providers on vaccine storage, handling, and administration of all 3 vaccines, communication toolkits to be used by jurisdictions and providers for easy reuse and syndication, weekly communication updates and technical key points, vaccine frequently asked questions for vaccine recipients, and then recommendations to emergency departments and urgent care facilities and providing vaccine upon discharge. We keep this on our publicly facing website and are also in constant communication with the jurisdictions, localities, territories, and partners, trying to answer any questions so that we can keep this as an iterative process and keep updating our guidance that's coming out. I want to discuss a little bit our Vaccinate with Confidence program. So we know that the public needs to be confident and ready to receive their vaccine. Vaccinate with Confidence was a framework we created for other vaccine preventable diseases, and that was adapted for COVID-19. So on the slide, you can see in December 2020, 71% of the US general public said that they would receive a COVID-19 vaccine. And then in May 2021, this was 66% of US adults reported being vaccinated or intending to be vaccinated. So what were some of the factors that weighed on that acceptance? Side effects, how well does it work, how safe is it, and how much does it cost? We knew that we needed to address this. And so we saw that COVID-19 vaccine would be more acceptable if their healthcare provider said it was safe, if there was no cost to the individual, which has been a foundation of our program, and if they would help facilitate them getting back to school or work, and also if they could get it easily. So Vaccine with Confidence is also the trust that patients, parents, or providers have in the recommended vaccines, the providers who administer the vaccines, and the processes and policies that lead to vaccine development, licensure, and manufacturing. So throughout all of this, foundations of the Vaccinate with Confidence strategy were reinforcing trust in the system, in the providers, in the vaccines, as I just talked about, empowering healthcare personnel and providers with this information, and also continuously engaging communities and individuals throughout the entire program. So as we look ahead, we've come a long way and have had great momentum, but we still have much work to do. So looking ahead for our COVID-19 vaccine implementation efforts, we're focused on continued surveillance of variant viruses, continued vaccine effectiveness studies, expanding vaccine eligible populations, combating vaccine hesitancy with a continued focus on vaccine equity. So in closing, as I've said repeatedly, confidence in the vaccine program has been key. A trust in the vaccines, the vaccinators, and the system. These new vaccinations programs will bring vaccine to locations people trust as well, such as schools, churches, and community centers. A couple of lessons learned to date for our program. Early focus on stakeholder engagement has been critical. This has included the federal retail pharmacy program. Our community level engagement and local leadership have been essential for this successful program as well. And then communication and education have been cornerstones to this program, and they've been necessary to help us overcome vaccine hesitancy. So thank you again for inviting me, and I appreciate you guys listening.